the richest, most active life you possibly can, as free of health challenges as we can possibly help you get to. I just want to make it an inexpensive lifestyle if I can. And so that's where I come down. That's my answer.
If you let people talk later.
Okay.
I'm not sure. Are you seeing the insurance carriers, how they're responding to this? And as small business or business folks, are they forcing folks into the exchange more than expected?
You know, I think it's early, but one of the things that's forcing some people into the exchange is there's a lot of non-compliant policies out there, and that's that tens of thousands of policies being canceled this week. In Maryland, so far, the payers are behaving pretty darn rationally. So Blue Cross led the charge, and they have a full slate of products on the exchange. United has a full slate of products on the exchange. Aetna, we don't know what they're going to do yet. Cigna, we don't know what they're going to do yet. But it looks like they're going to go on the exchange. So I think, at least here at home, they're behaving pretty darn rationally. We've got to make some decisions with the Medicaid MCO, because if you think about it, there's a population that's going to move back and forth between Medicaid and the exchange, and we think we're going to have an exchange product, not the first year, but the second year, just so those people don't go through the extreme stress of changing coverage, because it's stressful to change coverage. So if we can figure out how to do that in a way that's seamless for that consumer population, we'll probably do that.
How do you see churches getting involved in wellness programs for the elderly and for children and other pieces of the population? What can we do to help the wellness end of things?
May I speak to that? I'm meeting tomorrow morning with Wendy Zimmerman, who's somebody you may know, and Cindy Earle, who sort of helps community education. And what we're hoping to do is to talk about some wellness programs that possibly we could run through churches, where the peer support group, the theory of it, that the peer support of a congregation, maybe led by the pastor, would encourage people to participate and lead healthier lifestyles. So if you can be patient, maybe in another month we'll have something to share with you as far as an idea. But that's in the works, and Mary Ritz was a part of that. We were talking about that last June already. And so we're even thinking of maybe trying to pilot it down in West Virginia too, with some churches down there. But we'd like to try to start it here in Hagerstown.
Well, I can give you a couple of examples of programs I've seen. One of them, first, you can overwhelm them if you come at them with diet and exercise. But, you know, let's start a program with our people who are having a hard time controlling their blood pressure. And let's focus in on what can be done to help with blood pressure. And let's get the parish nurses to run blood pressure clinics after services. And let's get a tracking and a monitoring. Let's help them understand about sodium at a practical level. Let's help them to understand their medicines and help them to get to a doctor if their medicines aren't working to control their blood pressure. I mean, that's a program that you could have a profound impact, and you haven't spent much in the way of resources to do that. So it's a simple thing, but you know, it's the number one issue is controlled blood pressure. So, and thank you, David. We keep him around for a lot of reasons. Bailing me out on hard questions is one of them.
I believe I heard you say that if we're already on Medicare, the Health Care Act is not likely to affect us much at this time. At what point will it affect us more?
Well, the worries, okay? The first worry is this act puts some pressure on the physicians to begin to report quality and maintain certain quality levels. And that really makes a lot of sense if you're a large, group practice. We don't have many of those around here, but if you're a Geisinger meeting quality standards, you're going to have professionals help you do that. But if you're in an office of 4 guys working, 15 hours a day and taking call, and you're gonna look at that and you say, you know what, it might be easier just to not participate in Medicare than to meet those standards. So I worry about we lose Medicare physicians, because they got plenty of work. I mean, you know, we've got lots of demand for services, so I worry about that. I think the play with Medicare is going to be these Medicare shared savings plans. The government's going to shift some reward to provider networks so they can learn how to manage care. And then I think what they're going to do is begin to shift risk. And, you know, that's a big deal. You know, we as provider communities have not managed risk like insurance companies manage risk. So this idea of the Medicare Advantage, it's called Medicare Advantage. If that occurs, then it has consumer implications. There's benefits inside the Medicare Advantage, but there's some restrictions inside the Medicare Advantage. Those are the two principal risks that I see. You know, between ARP and the fact that the population segment with the highest voter turnout is the elderly, I think beyond that, the risk is pretty limited.
I think electronic health care is a step towards that goal already, and those steps have been taken by Medicare to provide incentive to physicians and give them more and more, you know, rewarding them for using electronic health records. That improves their quality and quality standards too. So those kind of things you'll see happen, I think, bits and pieces, not as a global.
Yeah. And this is a journey. You know, it's getting a lot of media coverage right now because we just threw the switch. But first, the bill takes 7 years to be fully implemented. And I think it'll be a decade before we know whether, as an experiment, it's having any positive impact.
Earlier you said, and I hope I'm getting this right, access to primary care is going to get tough. And I'm not sure what that's going to look like and why you're saying that, is this on a personal level, we're gonna have a harder time?
I think on a day-to-day personal level, you're gonna have a harder time, particularly people looking for a new doctor. And if you've got an acute illness, whereas you might have an office that keeps 2 or 3 sick call slots a day, they may not be able to keep 2 or 3, they may only be able to keep 1, so you may see a delay in getting seen. You may see, if you're relatively healthy, you may see a nurse practitioner and go a couple years and not see your physician. I don't think that's bad care, I think it's just different care. So I think those are the kind of things. I think that for newly covered people, they got a card that may not get them in the door for primary care, or it may get them in the door 4, 5, 6 months down the road, which, you know, can be, is not helpful.
And that's because the market's being flooded with so many more patients.
So many more covered lives. And, you know, the typical primary care doctor, 3,000 is kind of an average practice size, 3,000 people. So you figure in Washington County, maybe we get 20,000 additional covered lives, but 15, 20,000, that's 5, 6, 7 doctors covers it.
How does urgent care centers fit into that?
You know, urgent care is a consumer version of healthcare. And I always think we have failed the patient every time they come to urgent care. Because urgent care is episodic care. And episodic care is expensive, and it tends to put the fire out, but it doesn't do anything to advance the health. What I think is going to happen now, because we've begun to look at this, we're going to start creating permanent medical records in urgent care, and because there's big gaps today, you're going to start seeing urgent care turn into primary care for 4 or 5 hours a day, and schedule patients for routine primary care, and then convert back to urgent care at night. Because there are primary care physicians there attending patients, they got lots of resources there, and your visits per hour drop off midday at urgent care. So I think it can become a useful tool, but right now the way urgent care works today, it's why there's these big companies in it, is it's the fast cash exchange, and the care's not linked to anything, it stands out there on its own. You know, seldom does your attending physician get information back. So it's really, but it sells something the consumer wants, which is care when I want it, my way.
What about some of the concierge medical practices that are, I mean, we don't have any that I know of in Washington County, but I know there's some in DC and other places. How do you see those playing a role as?
Well, I think anytime, you know, we got the underpinnings of a two-tier system, but we've kind of always had it. It just got formalized. And I think it's a legitimate solution for people that want to spend their money on having a different level of access to care. I didn't know what to think. My personal physician, when I lived on the Eastern Shore, became a concierge practice, and he was charging $1,500 a year to be one of his 500 patients, and he had a practice of, I don't know, probably 3,500 patients at the time he did it. And you know, my wife and I were both patients, and we loved the guy. He was a duck hunting buddy of mine, and good, you know, really good internist. And I could afford to have paid that, but and this was the moment for me. I had 1,500 employees that were his patients who couldn't afford to pay it, so I left the practice because I couldn't kind of look my employees in the eye and stay. That was how I sorted it out for me. My wife still kind of grumps about that. She really liked it. So I think it's there. It's a reality for some people. I'll tell you, if when I hit 70, I've got congestive heart failure and high blood pressure and maybe something, you know, early stages of diabetes, then my priority would be to put my money in my health, and I would participate in one if it were available, because that extra access would be something I would value. But it's not for everybody, and it's not going to be for everybody, just like a Cadillac's not for everybody. Some of us have to drive Fords.
Do you think Walmart and Walgreens clinics will thrive more in this?
Oh, I think Walgreens and Walmart are going to have a tremendous impact in healthcare. I think that the largest provider of primary care at the end of this decade will be Walmart. They're moving very fast, and that's my kids. I apologize. And you know, we are intrigued by Walgreens, who are making a very definitive play in what I call primary care light. So they don't want to be your primary care. They want to keep a very low level of engagement in primary care and use support specialty care. So they're putting nurses in their pharmacies, nurse practitioners. It's a really, really effective model. We just negotiated a deal with Walgreens. You might have seen it in the paper. We've run a chain of pharmacies for a number of years, and that business has changed. As Ray Gray, our CFO, says, we can't sell beach balls cheap enough to compete anymore. And the point is, we don't sell beach balls. But it's interesting, pharmacies have changed. I mean, 3% of the operating margin of pharmacies come from prescription drugs. 97% come from the stuff out front. And the only reservation I had about the Walgreens transaction, we got a good deal. We've got a lot of commitments to the community, and we've got a deal for our employees and all of that. They sell tobacco in their pharmacies. And you know, it's like I said to their regional manager, at some point you gotta choose sides. You know, you can sit at the 50-yard line for a while, but you know, you're either a healthcare provider or you're just another guy on the corner selling whatever people want to buy to make a buck. And you know, for them to be a long-term partner for me, that's really gonna be an issue for me. We shouldn't make it easy. So, other questions? You've been a great bunch. Thank you all very, very much.